And now let me take this opportunity to introduce Prof.Bancha Chernchujit. Prof. Bancha is currently working in departments of orthopedics, Faculty of Medicine, Thammasat University, Klong Luang in Thailand. He graduated from Faculty of Medicine, Siriraj Hospital, Mahidol University, Bangkok in 2000. He obtained his certificate in sports orthopedic and arthroscopy surgery, Technical University of Munich. He later obtained his fellowship in sports orthopedics from the Department of Orthopedics and Sports Medicine, Technical University of Munich, Germany. So in 2004, he obtained his fellowship in shoulder surgery, also in Germany, but this time in the Department of Orthopedics and Sports Medicine, University of Würzburg in Germany. He's a member of the Thai Medical Association, the Royal College of Surgeons of Thailand, the Royal College of Orthopedic Surgeons of Thailand, American Academy of Orthopedic Surgeons, ASCA. He's a member of ASCA, ISACOS, APCAS, and ASA membership. So without further ado, I would like to invite Prof. Bancha. Thank you very much.
Thank you for your kind introductions. Thank you so much for inviting me today. Thank you. So today I'm talking about the HA, in injection in osteoarthritis, clinical perspectives and advances. So I want this section to be more interactive because this is after lunch. Please question and answer. If you have doubt or you have any suggestion or sharing your experience, feel free. Okay. So this is the recent pictures I just got from yours. Thank you so much. So a nice picture, the group pictures of us. So it launched in Asia, in Thailand since 2007. It's long time back. And we have a very good outcome and also safe profile. So we have no complication or side effect from these HA injections. So this dual action, you have the pharmacological properties, inhibition of inflammation, induction of HA biosynthesis, chondrocyte proliferation, pharmacological effects, and also mechanical effect is of course is shock absorption and also lubrication. So previously is indicated in patients with osteoarthritis, okay, that failed to respond from conservative treatment. But right now the indication extended. I just discussed with the team that now it's not just the osteoarthritis, we still have some indication. Like you mentioned about the frozen shoulder, osteoarthritis of shoulder or hip or ankle, now is what accepted to be extended indication. Like you saw many articles, okay, like they use that in postoperative knee surgery, arthroscopic surgery, meniscus surgery, cardiac surgery, PF arthritis, okay, in rotator cuff disease, osteoarthritis, and also frozen shoulder. Especially in sport medicine, right now, there's a lot of elite level athletes that are prone to have the joint degeneration, right? Because right now we are very active in sport, like running is very popular in Thailand. We have early arthritic change. Even we are 40, 50, we start to have arthritic change. Okay, meniscus degenerations. Not every patient needs surgery. I think this is another ways before you jump to do the surgery. Okay, you can postpone the surgery and also reduce the joint stiffness like frozen shoulder, traumatic arthritis. Okay? The goal is to improve the pain and function, to inhibit the expression of inflammatory mediators, to stimulate the synthesis of HA, proteoglycans, and protection of the cartilage, and to reduce the gliding resistance and risk of adhesion. So this is the societies that accept. You look at this information, URA, right? ORC, ALS, okay, American College of Rheumatology, okay, Visco, ANA. So these are accepted, and also accept this HA injection as the treatment option. So if you look at this information, you see that the strongly acceptable is the early arthritic change of OA, young age. okay, and also sports. Yeah, this is strongly recommended, yeah, for treatment. So you can use it in mild to moderate or even severe, but the purpose may be different. The mild to moderate, you improve the pain functions, anti-inflammation, and that is structural modification. But in severe patients, yeah, you can just buy the time, like you can postpone the surgery. Sometimes the queue is really long, you can postpone the surgery time, okay? And some patients are not proper, it's contraindicated to do surgery. You can relieve the patient's symptom. This is like a part of palliative treatment, yeah. I have many patients that have heart disease, they have like severe kidney disease that are not proper or contraindicated to do surgery. They are happy to come every 3 months for injection, 6 months, and then they can have better life. Okay, I think this is a very good tools. Instead of steroid, in the past we used a lot of steroid, but you know there's a lot of side effect from the steroid. Okay, so we'll talk about the injection techniques. Yeah. So I have some publication about the injection because I'm the keyhole doctors. I'm the sport medicine. I do a lot of surgery, knee and shoulder. So I put the camera in the joint every day. So I know where is to put the camera in, where is the pocket. So with a simple way, yeah, I give you the ideas. The injection techniques, once you are hit the cartilage, that means you are in the joint. Okay, so you can put the needle in the joint, but try not to damage the cartilage. So that's my simple way. If your patient have arthritic change, you can bend the knee. The patient come to see you with in the wheelchair, right? You don't need to put the patient out of the wheelchair, put on the bed. That's struggle. Yeah, you can inject when the patient on the wheelchair like 90 degrees. So your needle, use the smaller size because the Hyalgan, the molecular weight is not too big. So you can inject like 25 G needle, okay? You inject, if you arthritic change on the medial side, we will not inject on medial because once your cartilage touch the cartilage, your needle touch the cartilage, that produce pain. So I will inject on the lateral side. So patient always ask me, why you inject on this side? I have pain on my medial. Why you inject lateral? I said, this is the same pocket, same cavity. I inject on this side and the drug will get, yeah, and that will be in the same cavity. So the trick is that I will show you the technique. First, I will put the small needle in the joint. So I show you the landmark here, okay? So I do start with my injection. Okay, I touch the cartilage and then I blow a little air into the joint. Okay, there's many articles prove that when you put the air in, you have more space. Okay, and that not introduce any infection, 0%. There's many study and we did a study also. And you have this pocket and then you can follow by your HA injection, right? So the first and then we inject the HA into the joint. So after the injections, okay, so that will mix into the same cavities and then you can hear the screeching sound. Can you hear? That is the screeching sound, yeah. That means it's like you're shaking a bottle. Shaking a bottle. After injection, it will mix together and the patient feel, oh good, I have fluid in the joint now. Yeah. So that's worked very well, yeah. And we compare the injections from the routine supralateral and injection from the lateral soft spot. We found that this more accurate. Accuracy is 90 to 95%, yeah, and also less pain, yeah. This is another screeching sound. Can you hear that? And that proves that your injection is in the joint. Once you inject, okay, you can hear the screeching sounds. And if you check the X-ray, you can see like air fluid level. You can see air and also the fluid in the joint. That means you're in the joint, okay. And I also apply this for my shoulder joint, yeah. Okay, and you don't need to inject like anesthetic agent like silocaine before, because your needle is 25 with the same needle, okay, one shot, yeah. and very happy. So this is our study. You can see that after you, we did the study comparing this injection. You see the air here. That means your injection is in the joint. Okay, and that is very accurate comparing to the supralateral injection. Yeah. Okay, we start. This is the, if you have arthritic change on the medial, I always go lateral. But some patients have walker's knee. I inject on medial side. Okay, that is the injection technique. And my patients say injection is same like vaccination, sometimes less pain. Yeah, don't make a big needle. It's because HA molecular weight is perfect. You use number 25 is okay. Yeah. So this is another study of my injection techniques for the shoulder, right? So the shoulder joint is, I think many of you use ultrasound, right? Ultrasound for injection, but it's not available everywhere and sometimes complicated. Yeah. So same techniques. Shoulder joint is a big joint, right? Once your needle touch the cartilage, you are in the joint. But keep in mind when you inject, please be gentle. Not touch the cartilage too strong, because we will go through the cartilage and then go to subchondral bone. That also produce pain. But if you just touch the cartilage, there's no nerve ending on cartilage, right? The patient will have no pain, right? So we did the study comparing this injection from the front, from the top. We found that the accuracy is the same. Yeah, yeah. So this is the shoulder injection techniques. Yeah. So this patient have the arthritic change of the shoulder joint. So now we inject from the front, right? Actually, you can inject from the back, okay? From the top, from the front, okay? But not from underneath. There's an axillary hair here. So you can go back, top or front, okay? Because it's the same cavity, right? But from the study, from the back, this is less accurate, because the shoulder joint is more in the front. Your needle sometimes cannot penetrate into the joint. It's too short, especially if you have the big size patient. So coming from the front or from the top is more accurate. Yeah. So my landmark is the AC joint. You can feel your AC joint. Everyone have AC joint, right? Here on the top. And then from AC joint, you can feel the soft spot. Just in front of the AC joint, that is the soft spot. Okay, this soft spot is between the CA ligament and the coracoid process, right? From this soft spot, it's very thin. I mean, from the needle number 25G, 1.5 inch, you can be in the joint for sure, right? Okay, and after cleaning, and then the concept is that you should go like this, because this is the head, right? You should not go to middle. You should go lateral, because your head is here. Yeah, you're coming from the top and then hit the humeral head, right? I'm show you. Okay. After cleaning, then you can see this is the AC joint on the top right here. AC joint just in front of the AC joint. Yeah, like that. And angle 30 degree down and then 30 degree, right? And then you can hit something that is only humeral head. It's not glenoid, because you're going lateral. Okay, I brought the air. Sometimes you can see the backflow from the joint, okay? And then you inject HA. So this patient is very happy. He come to see me every 6 months because he like playing golf. He have arthritic change, but he's still playing golf every day. Very happy. He come for injection and then golf, and he get very good scores after injection. He's very happy, and he denied surgery. He went to see many doctors. The doctor said, hey, you need joint replacement. But the patient said, joint replacement, I cannot play golf anymore because it's a prosthesis, right? The doctor did not allow me to play golf. I'm happy to play golf and come to see you every 6 months for injection. Yeah. So this is the landmark injections, right? That is another way. You can inject from the top also, okay? Like this. Okay, that is the cavity here we call navicular portal. You can feel it's on the top of your shoulder here. That's the small soft spot on the top, just behind the clavicle. Okay, but from here you should inject going lateral, not vertical, because you hit the glenoid. Okay, you go lateral. But from here you will pass the superior capsule and then through the rotator cuff on the top. Okay, and then you touch the head, right? But the drawback of this one, the needle should be longer. 1.5 inch sometimes not enough. The average is about 4.5. So if you have big size patients, not enough. You need spinal needle to do the injection. The spinal needle is not available at the OPD, right? So for me, mostly I use the anterior portal. We call this the superior portal. Yeah. Okay, like this. You see, this I use spinal needle. Okay, when getting, I hit something that is the humeral head. Okay, this is the, and then when I blow the air in, you see the that's the backflow of the air. Okay, and then do the HA injection. Yeah, we call this superior supromedial approach. Okay. For the hip joint, you can inject into the peripheral compartment or the central compartment. Okay, so you can use contrast fluoroscopy or fluid backflow technique. Yeah, I show you here. So this is the hip arthroscopy. Yeah. You can inject into the central compartment like this, or you can inject to the peripheral compartment. But once you inject into the joint, you can see the air backflow or the fluid backflow. Yeah. Okay. Also the ankle joint. Yeah. So I do less ankle injection. Mostly I do shoulder and knee. Right. This is the injection when I perform the ankle arthroscopy. Yeah. You can go to the anterior compartment using the you see, yeah, the medial or lateral soft spot. Yeah. So this is 92 years old. You see, heart disease, COPD, renal failure. She came to see me every 6 months, yeah, for the injections, yeah. And you see, she's on the wheelchair, okay. So we can inject for her on the wheelchair. She don't need surgery. I inject for her every 6 months, and she's quite happy. Now you see, this is very severe Wallace knee, okay, and she's not fit to do surgery. Right now she passed away just last month, but she followed with me for 6 years. Yeah, she just her daughter came to see me, told me that the mother passed away, and thank you so much for taking up her mother for 6 years. Yeah. So every time she came and I do injection. Look at this. This is my landmark, right? You draw the patella. This is the lower pole patella. Okay, you draw the line. Then you can feel the lateral soft spot. You draw this line and also perpendicular line to the Gerdy tubercle. Not too close to the center. If you close to the center, you are close to the ACL, PCL, and fat tissue. A lot in the middle. So you should go a little bit more medial or lateral. Okay, and your needle not inject into the center, but to the cartilage. Your target is cartilage. Okay, like that. Yeah. After cleaning, then we put the needle in. If you're very parallel the joint, you will hit the posterior part of the condyle. But if you're not parallel the joint, you may hit the front. The needle will be short. But if you are very good, you can touch the posterior part of the condyle, right? That will be far away from the anterior capsule, right? Okay, but anyway, you are in the joint, okay? And then HA injections, yeah. Okay, also opposite side, yeah. The same. I think does it hurt? She said very little. And the trick is that when you inject, you should not talk about your injection. You should talk about something like, where is your house, what, how many doctors you have. So not focus on the injection. Try to distract the patient talking about something, yeah, that's not about the knee, okay? And the patient will forget that, yeah. Okay, so right now she's happy. And this is after injection, she can start to exercise and walk, right? So this is the oldest patient I treat. You estimate how old? 103, okay? She's very old, and she came to see me. Said, "Doc, first time she came to see me when she was 100. She said, Doctor, please do the joint replacement for me. I have so much pain." I say, "No, you're too old, 100 years. So if something wrong, your family will blame me." So I follow her until now. She's 105. She's still alive. Yeah, very strong. Yeah, and came to see me every 6 months. Yeah. So the HA injection about the post-op knee arthroscopic surgery, this become very more and more popular. That prove that it reduce the post-op pain and improve the muscle rehabilitation and also reduce the stiffness after the surgery. Okay, this is another papers comparing the HA injection and no HA. You found that the patient have less pain and also better rehabilitations. This is another article. Also improve the less VS score and also more fraction at 6 months. Less pain. Especially the patient that have multi-ligament injury. We have in Thailand, we have a lot of motorcycle accident. So a lot of stiff knee, especially the multi-ligament. Like in provincial hospital, we have many surgeons for provincial hospital. So this patient, it is the off-label. Yeah, we use that because the patient have prolonged immobilization, multiple surgery. I did some injection that the patient have less, less stiff after the surgery. Yeah, because this patient there will be a lot of arthrofibrosis. I think that worked very well. Yeah, instead of steroid injection, because if you inject steroid for this kind of patient, you have the chance of infection because you have the reconstruction surgery, you have graft, especially you have sometimes an allograft. So that increases the chance of infection. So I try not to inject the steroid for this kind of patients. Okay. And also we have a lot of like this. After the reconstruction, like ligament reconstruction, ACL, and some flexion contracture or knee stiffness. Okay. You see, stiff 90 degree, 100 degrees. So the viscose supplement will reduce the noising sound. The patient can feel like in the joint there's some like noisy crepitation after surgery. Okay, because I think because of bone dust or arthrofibrosis. Yeah. So after injection, you see that in this patient when you put the air in, there will be backflow. That means the joint volume is very little. That's why there's backflow. Immediately you push the air in, there's a backflow. This backflow proves that, number one, you are in the joint. Because if you are in the soft tissue, there will be no backflow. And number two, that means the joint is very stiff, less volume, right? So after that, we encourage the patient to exercise and mobilization. I think for me, this worked very well. Because I'm dealing with the patient that have stiffness after the surgery a lot. Even I myself or my colleagues send to me, yeah. So this patient have the noisy sounds after ACL reconstruction. I think because of the delayed rehab that create the arthrofibrosis. Yeah. So this is in Thai means the sound is better and has better range of motion and happy. Yeah. Okay. This is a bit off-label and cannot reimburse because the patient is young, right? But I think that's worked very well and very safe instead of steroid. Yeah. Okay, and there's just many papers that about the after ACL reconstruction that play a big role in mechanism of action in chondroprotections and speed up the post-op recovery. In my hands, I'm taking care of a lot of national athletes. So in my hands, I had a volleyball player, you know, volleyball, basketball, and also the badminton. They always have PF joint arthritis because they jump up and down, and their PF joint is so bad. If you move the knee like this, it's so bad. You can feel the crepitation, right? So this patient came to see me. Even they try full conservative, but sometimes the performance is not so good. So I did that for her, and every time she got the medal, yeah, and back to me, hey, got the medal after injection, yeah. It's not doping, yeah, it's not doping agent, right? No problem, yeah, it's not the steroid. So the study proved that the PF arthritis patient doing very well because you're dealing with a lot of patients with PF. I think this is the very difficult problem, right? The PF is very difficult for me. So I think the training and also the HA injection works very well for PF arthritis patients. And this is a study they found that the significant improved of the score and also the Kujula score after HA injection for PF patients. Yeah. And this another athlete is also have the PF problem, the short push. Yeah, the big guys PF arthritis. Yeah. And this PF arthritic patient that perform the tubercle osteotomy, right? You see the PF is so bad. Okay, so after we performing some microfractures, there's an article proof that if you combine microfracture with HA injection, that will improve the qualities of the cartilage. Okay, after the surgery. Yeah. So in this patient that have the cartilage surgery, I always add the HA-Hyalgan for the patient. That can improve the cartilage regeneration, yeah, after surgery. And the patient feel very good. I mean, after surgery, I feel when I move his cartilage, he feel the pain is less and less capitation. Yeah, yeah. Also, this is the very famous football player in Thailand. He is very active, but he started to have arthritic change of the hip joint, but he's still very active. He's a natural athlete. Yeah. So I inject the Hyalgan for him. Okay. Every 6 months or 1 year. Okay. But after injecting, his performance is very good. Yeah. He's back to game and very active. So this is my friend, my very close friend. I think all the Thai doctors know him very well. He's very active. He look at his PF joint. It's so bad. Yeah, he's also meniscus tear. So I did the meniscus repair for him. Yeah, both sides, but not the same year. I think you were there too. So this is the people in the room. That means he's very famous and a lot of people come to cheer him. He's here. I'm here. Yeah. So I did the meniscal repair and his PF joint is very bad. So I, because he's in Chiang Mai, so I'm in Bangkok, I cannot inject for him. So I asked the fellows inject this for him. Okay, you see this Hyalgan? Yeah, he said very good and he's improved. This is his fellow. Yeah. Did the injection for him after the surgery. Yeah. So especially after surgery, the patient always have weak quadriceps. Okay, even you have PF arthritis, the PF pain will be worse after surgery. So I think you need something like condyle protection, yeah, to protect the cartilage after surgery. Yeah. Yeah. Okay. So now he come back to be active again. Yes, both sides. And also there's articles mentioned about the HA after HTO. Yeah, I think we have a lot of HTO patients, especially the runners. So this article proves that after surgery MRI, there's increased total cartilage volume and also prevent the loss of cartilage and lower amount of NSAIDs consumption. Yeah, after the HA injection. I have a lot of post-traumatic. I think Dr. Papon, he's a trauma man. He also have a lot of the arthritic change after the knee injury. Because in Thailand we have a lot of motorcycle accident, and our problem is stiffness after the surgery. Yeah. So like this patient has stiffness, okay, after surgery. So after the visco injection, he's very happy. This patient have the trauma like this. Yeah, so bad trauma. Femur, tibia, plateau, everywhere, and stiff, yeah, after surgery. So he came to see me with stiffness, severe stiffness. Okay, like this, he flex less than 90 degrees. Okay, very bad, and so extension deficit. So the bone heal very well now. So I get in and I do a lot of, I make arthroscopic release, okay, manipulations, okay. You see, we need many fellows to do manipulations. and after that, that's a fracture because of aggressive manipulation. Yeah, we can hear the crack, so we stop. Okay, what happened? And then we check X-ray. Oh my God, that's another fracture. So we put more screw. You see, we put another 4 screw here. Okay, and okay, we should continue. We should continue. If you immobilize the patient again, then we stiff, more stiff. So we put more screw and we start to do rehab like this. Okay, and HA injection for him, right? So right now he's very, very happy. Yeah, has good motions and good mobilities. So after HA injection, crepitation sound is improved. Yeah. So this is another, I think, indications for stiffness after post-traumatic injury. Yeah. Instead of steroid, I think HA work very well. Also, we had a lot of patients with OA shoulder. OA shoulder is not like knee arthritis. Knee, you cannot go, you cannot travel because you have pain. But shoulder, you did not use shoulder for walking, right? So if you use it less, no pain, you can live with that. You have no night pain, that's okay. Yeah. So many shoulder patients, arthritic chain, they can live very well, good ADL after the conservative or injection, right? So like this patient, you look at the X-ray, look very bad, right? But after the injections, you see, the motion is getting better. Yeah. Yeah, and he said, at first I cannot elevate my arm. Okay, after injection, HA-Hyalgan. Crepitation is less and he feel much better. Yeah. So, I think it's work well. It's different from rotator cuff tear. Okay, rotator cuff tear, the function is bad, right? You cannot elevate, you have so much pain. But also arthritis, you have good rotator cuff. Okay, you can elevate, but you have stiff. Okay, your problem is that you have stiff and also crepitation. If you use HA, that would help a lot. Yeah. Okay, and she's also arthritis of the shoulder. Also, she's stiff. I inject this from the top, right? So I forgot to tell you that the inject technique of injecting from the top is that you inject the needle like 30-degree direction to the head. You're looking at lateral epicondyle, okay? So if you go from the top, this direction, you're pointing lateral epicondyle, okay? And then you can have, like you see, here's a very stiff, okay? And then we get the HA injection, right? Okay, like this. But if you use the number 25, 1.5, that means you need to be, the whole needle should be in, yeah. Otherwise, you are not long enough. Okay. For the shoulder, sometimes if the patient is okay, I inject 3 shots in the same time. Yeah, because at that time there is a COVID time, patient cannot come often, so many times I inject 3 in 1. Yeah, and sometimes the patient stay very far from the hospital. Okay. Okay, this is another patient after rotator cuff repair with the rotator cuff. Okay, we inject. This time we inject from the front. Okay, we start with the air first. You see the backflow? The backflow means you are in the joint. Yeah, and also that means the shoulder is stiff. Okay, then you repeat HA injections. Okay, after injection, I always test the motion. You can hear the switching sounds. Can you hear? Yeah. Okay. And to check that you're in the joint. But if you're not in the joint, you're in the soft tissue, the patient will have so much pain and sometimes cannot go out of the room. Then the patient walk to see you but go back with wheelchair. That means you're not in the joint, you're in the fat tissues. Okay, so okay, this patient have subcutaneous injections after the supracapsular reconstruction. Okay, so he have some feeling of the crepitation. I inject the HA for him. This is for subcutaneous, right? There's articles. Yeah, we just discussed with you about your practice, right? You inject in the patient frozen shoulder. Also works very well. Frozen shoulder, okay? Because right now when we are talking about the steroid, some patients not accept steroid. He always asks me, what is the medicine, you eject it from me and say steroid, you say no. No, steroid, you worry about steroid, you worry about the blood pressure, the diabetes. Many patients have diabetes, they worry about the sugar level after the steroid injection. Yeah. And many articles mention about the HA that have better range of motion, constant score, and pain after the injection. Right? This patient also have frozen shoulder. Yeah, we did the injections. Yeah, it's coming from the top. You see my directions? Yeah, in frozen they always have back flow. Direction of needle is toward laterally, okay, and aiming to the lateral precondi. Okay. Okay, this is HA injections. But anyway, the steroid is still the gold standard in frozen shoulder, right? And this is alternative. But most people still using steroid. I'm not blaming the steroid. Steroid is also good, but you need to know how to use it. Yeah. If I use steroid, I use very low percentage. I use only 20 milligram of triamcinolone, right? Not 40. That's a paper proof that 20 is enough. You don't need to inject 40 milligrams. Yeah. So in conclusions, the HA injections now approved by many societies, right? It's safe drug, okay? And also right now the extent indication for the HA injection, right? Like I show you in many scenarios, right? And now I want to know your ideas, question and answer, and sharing your experience. Okay, thank you so much.